I think that's a wonderful case that has been displayed. So I think 2-3 things that I would look differently. Now, what I see from the angiograms that have been displayed is that I don't see major interventional retrograde collaterals from the left system supplying the right. So a good septal I don't really see. There's probably some epicardial from the distal LED that's supplying the right coronary artery. So if at all I wish to do this, I would probably go at a reattempt to the RCA, and that will be an antegrade approach. Probably I'll give it some time because some dissections have been already made by your approach, and then we don't want a wire to go in immediately. So probably 3 to 4 weeks later, I'd get this gentleman back, do a contralateral injections again. I'd take more orthogonal views. So from the views that I saw, the right coronary artery, the wire had gone into the false passage. Probably more orthogonal views will tell us whether you're really in the true lumen or you're going out of the lumen. And that's very important when you're doing these C2 interventions. The guide cat support with a GR is something that's a little flimsy, and probably go with something that is more supportive and go with an Amplatz left. If at all you're worried about damping of pressures, you can make a small side hole there to make sure that you're not getting worried about it, and use a microcatheter. This is something, these two steps are something that are non-compromisable. So a microcatheter is something that we use always, so we don't compromise on that, because it gives you the chance to cross your wires and exchange your wires more easily. The wire escalation technique is something that we follow very meticulously, and then rushing to a Conquest Pro would probably not be something that we do in this case. We'd start with a more tapered wire and then see the artery, how the lesion feels, and then probably move on to Gaia second or Gaia third. And if at all nothing, then yes, make Conquest Pro as your choice. Conquest Pro is a good wire, but it's mostly used for penetration. So it's a very tough wire. It's like a needle, so it'll go anywhere that you wish it to go. So if I just penetrate the lesion, I'd probably come back and fall back onto a less stiff wire there. If at all I'm in a false lumen, I think make parallel wires and make retrograde injections. So not too much of antegrade injections. You'll just keep on dissecting the planes. If at all the antegrade does not work, well, you'd probably use something for re-entry. So a Stingray or crossboss, if at all we have it here. The mid part of the RCA seems to have some calcium there. So even if after I cross the lesion, if given a choice, I'd want to look at the lesion more carefully, use some form of imaging, and if it's necessary, use some form of calcium modification, because the angiography may not show me the lesion in the mid part. Last approach, of course, may be a retrograde, but again, if the septals that I see are arising from the mid part of from the stent in the mid LAD. So that's not a great septal to really look for. But again, that's something we'll probably do a septal surfing, because sometimes you may not see angiographically visible collaterals, but you may be surprised because your wire may pass through. So channel surfing is something that I'll do in case the other approaches do not really work out. Yeah.